Hello everyone. How are you? Good morning for most of you, but good evening for also some of us. And I would just introduce myself a little bit, but I wanted to see if you can hear me guys very well and also see my screen right now. Perfect, perfect. Okay, amazing, amazing. So I will just introduce myself a little bit and then I will tell you what are we going to do in this webinar. And I believe it's going to be like useful and at the same time, hopefully not boring, and it will contain the most important stuff that we will be discussing regarding the neuroanatomy. So first, my name is Karim. I am the head tutor at the Match Guy, and I scored 279 on my Step 2 exam, and I have been teaching and tutoring Step 1, Step 2, and Step 3 for a couple of years right now. And what we will be doing today is that we will go through the most important neuroanatomy stuff. I believe that yes, neuroanatomy can never be done in 1 hour. And usually, even in the crash course, which is a review, we do it in like 4 and 5 hours. We do the whole neuro. But something very important, and Angie is also reviewing the neuroanatomy today, is that what I can reassure you or what I can tell you from today is that at least after this session or after this hour, it would be pretty easy for you to at least understand how to identify these neuroanatomy lesions, and hopefully it will be a little bit easier for you to understand like how to answer these spinal cord lesions or these brainstem lesions, because from what I figured out, these things are extremely confusing for some. So we'll try to find an easy ways to address them with each other. Okay. After we do this, we will go through them in a PowerPoint. After we do them in a PowerPoint, we will try to answer few examples or few questions on them from our like Synapse QBank. So let me share my screen here. So perfect. Can you see my screen, guys, right now? Good, good, amazing. Amazing, Sumaya. Amazing, guys. Perfect. So let's do it. So things we will be discussing right now is the cerebrovascular lesions and how to localize these lesions with each other. We will also be discussing like how to answer any brainstem questions with each other. We will be discussing also how to answer any spinal cord question with each other. And we will also discuss other high-yield anatomy facts that usually shows up on the exam. And we'll answer few questions and we will apply this knowledge that we gained afterwards. Okay. And let's just start without wasting time. And the way I first like always tell my students is that any questions that shows up in the neuroanatomy, you should first try to imagine it into your head, and then you need to try to answer it. But before you even do this, you need to understand what are the structures in the brain that they can ask about, and just to get a general idea about these structures and what are the questions they are going to ask about. And the way I explain them, like these facts, is very simple. I tell them I need you to treat the brain or the neurology in general as few specific structures. We have the cortex here, as simple as it is. Do not try to complicate this. And then we have the internal capsule, and then we have the thalamus, and then after the internal capsule and the thalamus, we have the brainstem. And then after the brainstem, we will be having the spinal cord itself. And if you treat things simply like this, it will be a little bit very easy and straightforward to answer the questions. And then I told them what they are going to ask you on the neuroanatomy is that they will give you a person, and this person is having a problems in one of these structures. Then they can ask you to localize the problem. Is it left? Is it right? Or which artery supplied? Or another thing they are going to tell you or they are going to ask you, for example, is that they will show you like the same person and they will ask you like if this person is having like an internal capsule problem, what are the specific like lesions findings you will more likely to see. So the best way I approach these things is that I first understand, and 1 second because I think there is annotations here that Osama is doing, so let me try to delete this. Okay. So the best way to approach these questions is that I first understand what are the arteries that supplies each spinal cord structures, and what are the arteries that supplies the brainstem and the thalamus and the internal capsule and the cortex. And after understanding the artery supplies, I then understand if there is problem in this artery, what lesion I would get. So in the internal capsule first, I need you guys to get three arteries that supplies the cortex itself, and then the internal capsule, and then the thalamus. And the lecture will be recorded, hopefully, Raza, and I will ask the support team if it would be shared or not. So let's start. So first is the cortex. I need you to know only three arteries, guys. The first artery is the anterior cerebral artery, and then the middle cerebral artery, and then the posterior cerebral artery. These are literally the three most important arteries in the cortex itself. Okay? And what I need you to know is that if you have problem in the anterior cerebral artery itself, the person will get a problem, and this problem would be on the legs. So for example, if you have a stroke in the anterior like cerebral artery, the person will get a leg weakness, for example, or a leg like sensory loss or whatever. But the most important thing I need you to know is that it will only affect the legs, and that's it. So anterior cerebral artery problem will only affect the legs, and that's it. The other one is middle cerebral artery. And if you have a middle cerebral artery problem, you will usually get a lesion, and this lesion will supply either the arms or the head or both of them, but nothing else. And that's very important. So anterior cerebral artery will supply the legs only, and middle cerebral artery will supply the head and the arms only. So if you see a person and this person is having like weakness in both legs, arms, and the legs, and arms, for example, and the head, it's never anterior cerebral artery or middle cerebral artery, because these things either affect the legs only, anterior cerebral artery, or arms and the head only, which would be middle cerebral artery. That's the first fact I need you to know. Okay? Then the posterior cerebral artery is not even like important for this neuroanatomy, but it's important for the vision. So if you have problems in the posterior cerebral artery, you will get vision loss. You will get something called contralateral hemianopsia with macular sparing. Okay, guys? So that's for the first part, the cortex itself. The cortex either supply the legs only, which would be the anterior cerebral artery, yeah, it supplies the legs, or it will supply the arm and the head, which would be the middle cerebral artery. Okay? If you see a person with the whole body affected, then it's never the middle cerebral artery or the anterior cerebral artery. Okay? That's the first part. Now, the second part that I wanted to discuss with you guys is that if you have an internal capsule problem, or if you have a thalamus problem, what you will get is that you will get a problem or a disease affecting one half of the body like that. One half of the body like that. Okay? And that's a very important like questions they will ask you. They will tell you if the person is having affection in one half of the body, where is the structures? So it would be either the internal capsule itself or the thalamus. So again, legs only would be anterior cerebral artery, and arms only and the head would be middle cerebral artery. Now, if they say one half of the body like that, then it's either the internal capsule or the thalamus itself. Okay? And they will ask you to differentiate between, is it really an internal capsule problem, or is it really a specific thalamus problem? Okay? So here is how I differentiate between them. Internal capsule problem will usually cause motor weakness. Okay? Internal capsule problem will usually cause motor weakness. Thalamus problem, thalamus, that's how I remember it. Thalamus will usually cause sensory affection. So if you get sensory loss of one half of the body, that would be the thalamus itself. If you get motor loss of one half of the body, that would be the internal capsule itself. Now they will ask you, and that's a very important question, M. Jamil, what are the arteries that will supply the internal capsule and the thalamus? And that's the questions they usually ask. And the answer to this is a very important artery called lenticulostriate artery. Lenticulostriate artery. So here. And they will ask you these two questions about it. The first question they will ask you, this lenticulostriate artery, how would it be affected? And that's a very high yield question on the exam. This lenticulostriate artery, what would affect it? And the answer is hypertension, guys. And that's a very important fact you need to know in general. In general, hypertension is the most important risk factor for stroke. The second most important thing they ask you, what's the most common artery that hypertension usually affects? And the answer, it usually affects the lenticular striate artery. And the way it do it is by two ways. The first way is that it can cause hemorrhagic stroke in the lenticular striate artery. So it can cause hemorrhage, okay, and the bleeding and the microaneurysms, okay. And we will call this aneurysm something called Charcot-Bouchard microaneurysms. Charcot-Bouchard microaneurysm. The second way it can affect the lenticular striate artery Faizan is that it can cause something called lacunar infarction. Lacunar infarction. So it will cause something called lacunar infarction, which is what? It's something called arteriolosclerosis. Arteriolosclerosis. This arteriolosclerosis, guys, is similar to atherosclerosis, but the only difference is that arteriolo is in the small arteries. It affects the small arteries, and this lenticular striate artery is a small artery, guys. That's why it will affected by something called arteriolosclerosis, and it will cause something called lacunar infarction. So again, internal capsule and the thalamus are supplied by an artery called lenticular striate artery. This lenticular striate artery can be affected by hypertension. Why? Because we know that hypertension is the most important risk factor for stroke in general. And the hypertension can affect the lenticular striate artery by two ways. Either it can cause bleeding, something called the Charcot-Bouchard microaneurysms. Okay? And do not confuse Charcot-Bouchard microaneurysms with another microaneurysm called perianeurysm. Do you know, guys, what is perianeurysm and what would perianeurysm cause? Because I see lots of students confusing Charcot-Bouchard microaneurysms with perianeurysms or saccular aneurysms. Yes, perianeurysm, guys, will cause subarachnoid hemorrhage, which will tell you that we have a patient with the worst headache of my life. That would be perianeurysm or saccular aneurysm. On the other hand, the hypertension causes something called Charcot-Bouchard microaneurysm, which will cause lenticular striate artery problem and will cause problem in one half of the body. Okay. The other way it can affect the lenticular striate artery is by having lacunar infarction, by causing something called arteriolosclerosis. And I usually do not go in details like this, guys, but I know for a fact that each thing I have said here, they can ask you about it on the question itself. So the first question is that they will tell you a person with arm weakness only, that's middle cerebral artery. The second question, a person with leg weakness only, anterior cerebral artery. The third question, a person with vision loss, contralateral hemonymous hemianopsia, that's posterior cerebral artery. The fourth question is that a person with problem in one half of the body. I need you to look, is that sensory or is that motor? If it's a sensory, it's the thalamus. If it's a motor, it's the internal capsule. Both of them are supplied by lenticular striate artery. A question asked about it. Lenticular striate artery can be affected by what? By either hemorrhage or ischemia, like lacunar stroke. Now I will ask you a question, guys. They will tell you this. How can you differentiate between hemorrhagic stroke and ischemic stroke? Which one will appear on CT scan? So if you do a CT scan, which one will appear? Hemorrhage or bleeding or ischemic stroke? What do you think, guys? So if you do a CT scan, which one will appear positive on it? A hemorrhage or an ischemic stroke? So Sophia is saying hemorrhage will appear. Ahmed also, yes. Amazing, guys. Hemorrhage itself is the one that will appear on CT scan. So they will tell you a question and the person is having like one half of the body motor affection. So you know, let's say it's an internal capsule question. And then they will tell you CT scan is negative. Then they will ask you what's the most probable cause. And the answer, would it be like hemorrhagic stroke, like rupture of Charcot-Bouchard, or would it be lacunar infarction? So the answer would be lacunar infarction because CT scan is negative. So if CT scan is negative, it means it's not a hemorrhage, for example. So that's another question they ask. Now, let's go into the actual very important structures that they also ask on the question itself, which is brainstem lesions. Okay, and I know I am going very fast, guys, in these things, but I will approach it again. But let's go into the brainstem lesions and what's the best way to approach these lesions and how do I answer them on the exam? Pretty easy without complicating it for each other. Okay, so first we know that we have three brainstem structures, right? We have the midbrain, and then we have the bones, and then we also have the medulla. Okay, guys? Now, I know that like you have seen maybe some videos about brainstem structures, and you always tell you like, oh, you have to memorize which tracts are medial, which tracts are lateral in order to answer these questions. And in fact, I think that's far from the truth. The easiest way to answer brainstem lesions is this way, guys. And if you know this, even better than the rule of four, Sumaya. So I will tell you the rule of four, but I will tell you what's the best way I always answer brainstem lesions and how do I always answer it correct. So the first rule I want you to know is at first how to know you are in a brainstem, Sumaya. Like, how do I know that they are talking about the brainstem? They are not talking about like the anterior cerebral artery or the middle cerebral artery or the thalamus. Have you ever asked yourself this question? So yes, the first thing is that I figure out, is this a brainstem problem or not? And the way I know it's a brainstem problem is by something called cross design or cross lesion. What does it mean? It means that the person will have problem in one half of the face and the contralateral half of the body. Okay, that's called a crossed lesion because the lesion crossed from the right side of the face, for example, to the contralateral side or the left side of the body. So once I see a crossed lesion, it's a brainstem problem because if you go back, legs only are anterior cerebral artery, arms and head only are middle cerebral artery, and one half of the body in the same location would be internal capsule and thalamus. Okay, so across the lesion like this, guys, will be our clue or our way to know that we are in the brainstem. So that's the first rule, to figure out first you are in the brainstem. The second rule is the cranial nerves. If you literally know the cranial nerves, you can answer the questions. Okay, so what are the cranial nerves we have? We have 12 cranial nerve. 1 and 2 are in the brain, 3 and 4 are in the midbrain, 5, 7, 8, 6 are in the bones, and then 9, 10, 11, 12 are in the medulla. So the first 4 are in the brain and the midbrain. The second 4 are in the bones, and the last 4 are in the medulla. Okay? And can you observe the ones in the middle? 3, 4, 6, 12. The ones usually in the middle, guys, are the cranial nerves that have factor 12. So for example, can you see 3 multiplied by 4? They equal 12. 6 multiplied by 2 equal 12. 12 multiplied by 1 equal 12. So the ones that have factor 12, right, Jamil, will be the ones that will usually be in the middle itself. That's the first fact. Okay? The other cranial nerves will be lateral. So 5, 7, 8 lateral, 9, 10, 11 lateral. Okay? So that's the second way to know which cranial nerves is affected. Okay? And knowing which cranial nerve is affected will literally tell you where is the location. So for example, if they told you the person is having tongue deviation, what do you think, guys? Which cranial nerve would be affected then? If they tell you we have a person with tongue deviation, for example, so his tongue is deviated, which cranial nerve would be affected? What do you think? So there is tongue paralysis and tongue deviation. Yes, amazing, amazing, Ahmed. So this would be cranial nerve number 12, guys, which would be the hypoglossal. So this one, would, for example, will cause tongue deviation. Okay. If they tell you there is absence of gag reflex, what do you think, guys? Which cranial nerve would be affected? Absent of gag reflex. Then it would be, yes, 9 and 11, right? 9 and 11. Absent gag reflex or dysphagia. Okay. If they tell you, for example, the person is having, let's say, a symmetrical smile, what do you think, guys? A symmetrical smile, for example. Okay. Then it would be like always, yes, facial palsy. So this one would cause asymmetrical smile, for example. If they tell you hearing loss, then it would be cranial nerve 8, okay? So from the description itself, you will be able to figure out which cranial nerve is affected. So the second way is to figure out which cranial nerve is affected. If you know which cranial nerve is affected, it will be pretty easy for you to figure out where is the location. Because if they already told me it's tongue deviation, I know it's cranial nerve number 12. If they told me it's dysphagia and absent gag reflex, I know it's 9, 10, 11. So 12 will be medial medulla. 9, 10, 11 will be lateral medulla. So knowing where is the cranial nerve affected will tell me which cranial artery or like where is the location itself in the brainstem. Okay. The third thing that they will ask me, and this is something I have to know, is the supply of each location in the brainstem itself. So that's the hard part, but we can do it pretty easy, guys. 9, 10, 11 are the lateral medulla, right? The lateral medulla, because that's the medulla here. So 9, 10, 11 are lateral medulla. Lateral medulla is supplied by an artery called the pica, posterior inferior cerebellar artery. Okay. Now, how about lateral bones then? Lateral bones will be ICA. So bica lateral medulla, ICA lateral bones. Okay. Then the midbrain, luckily for us, we don't have lateral midbrain. We only have medial because we only have 3 and 4 medial. So medial midbrain would be posterior cerebral artery. And that's it. I remember that the midbrain is literally below the brain itself, below the cerebrum. So it will receive supply from the cerebrum, from the brain, posterior cerebral artery. Okay, so the medial midbrain, posterior cerebral artery. Lateral bones, ICA. Lateral medulla, BICA. Okay. Then medial bones will be supplied by an artery called basilar artery. Basilar artery. And if you damage this artery, guys, you will get a disease called locked-in syndrome. The person will have quadriplegia. He will not be able to move at all. Okay? The same locked-in syndrome is called osmotic or can happen from osmotic pontine demyelination if you rapidly correct hyponatremia. During rapid correction of hyponatremia, you can also get locked-in syndrome, and we will call it osmotic pontine demyelination. So you know if you affect the bones, especially the medial bones, or if you affect the artery that supplied, the basilar artery, you can get locked-in syndrome, which is quadriplegia, guys. Okay? And then the medial medulla. What did we say is below the brainstem, guys? So let's go back here. We said below the brainstem is the spinal cord. So if we know this, we know that the medial medulla is literally next to the spinal cord. So it will receive supply from the same artery that supply most of the spinal cord, which is what Ahmad Yas anterior spinal artery, guys. Anterior spinal artery. Okay. So now it's pretty easy that now we know each artery is supplied by what. So 3 things we will do again. We will ask ourselves, is this across the lesion or not? Then we will ask ourselves, which cranial nerve would be affected then? And then if we know which cranial nerve is affected, we will know the specific location of the brainstem. Then we will just figure out the region is where they can ask us about the supply, and we can figure this out. Now, a student can ask me, all of this sounds good, but I need to practice few questions on it. I will tell you, yes, let's do like 2 questions on this, okay, before we forget. But before we do this, I want to give you something very important, guys. In the brain, any lesion in the brain is contralateral. Okay. Any lesion in the brain is contralateral. The only exception to this rule, okay, is usually the cerebellum and the cranial nerves. These ones are ipsilateral, guys. Okay. So please know this specific rule. Any lesion in the brain will cause contralateral problem. So if you affect the right middle cerebral artery, you will get problem on the left arm and head. Okay. The only exception is the cerebellum. The cerebellum is ipsilateral, and also the cranial nerves are also ipsilateral. Okay. So if I tell you, for example, that, or let's answer the questions with each other, and then we will figure it out, guys. So I don't like spoil it for you, and we will try like to figure out how did we answer it and how did we reach the conclusion with each other. So can you see this question, guys? Let me like increase the text zoom a little bit. So that's like from our like new QBank, okay, the Synapse QBank itself, and we will try to read it with each other, and we will try to figure out what's the best way to answer this question. So let's read it. So a 64-year-old man is brought to the emergency department because of sudden onset of severe vertigo, nausea, and difficulty swallowing that began 2 hours ago. Until now, I didn't get any useful information. And again, guys, while I approach these questions, I always look for the keywords. Okay? He has 30 bagged smoking history and history of poorly controlled hypertension. So I know this person has a very high likelihood of having stroke because they have two important risk factors for stroke. The vitals are fine, blood pressure is a little bit high, and respiration is 16, it's fine, pulse is fine, and the physical examination shows left-sided ptosis and a constricted left pupil that's slow to dilate in dim light. Okay. There is also perceptible decrease in sweating on the left side of the face. So there is problem on the left side of the face in general. Okay. Neurological examination shows a loss of pain and temperature on the left side of the face and the right side of the trunk and the extremity. What do you think, guys? Is this line important or not? Loss of pain and temperature on the left side of the face and the right side of the trunk and the extremity. Is this specific line important or not? What do you think? And what does it tell us once we have seen this? Yeah, but it's very important because it tells us that this person is having a crossed lesion, right? Because this person is having a problem on the left side of the face and the right side of the body. Amazing, Elmi, amazing, Elena, guys, perfect. So we know now that we are talking about a brainstem lesion. We don't know where is the brainstem lesion yet, okay? Facial muscle strength and hearing are preserved, and when the patient is asked to say ah, the left side of the palate fails to elevate. Okay, and there is prominent post-pointing dysmetria, and his gait is unsteady with a tendency to lean to the left side. Okay, and they're asking which artery is supplying here. So this question is very hard. Okay, and the way I will diagnose it is that I know first it's a brainstem problem, but then I need to know which cranial nerves is affected. Okay, and there is one mistake I don't want you to do, guys. I don't want you to look at the ptosis and the constricted pupil and to think about like cranial nerve number 3, for example, because this ptosis and this meiosis and this anhydrosis is just from the sympathetic nerve damage because the sympathetic tracts are lateral. Okay, so it doesn't tell us anything. So the only cranial nerves that I can look at, and I know for a fact it's a cranial nerve problem, is the difficulty swallowing here. Can you see the difficulty swallowing, guys? And the dysphagia? So I know for a fact if it's dysphagia, which cranial nerves will be affected, guys? Perfect. So if it's dysphagia, I know this would be like cranial nerve 9, cranial nerve 10, cranial nerve 11, right? So I will just go back to my little drawing here, and I know that this is cranial nerve 9, 10, and 11, right? So cranial nerve 9, 10, and 11. So I know it would be the lateral medulla. So I know the answer would just be ICA. Okay. So can you see the best way to answer these questions, guys, is to always have in mind, like, first, I need to know it's a cross lesion or not. Because if I don't know it's a cross lesion or not, it would be very hard to answer the question. And then if I know it's a cross lesion, I look at which cranial nerve I know for sure is affected. Okay, so the ptosis and the constricted pupil can be just from like sympathetic nerve affection, and that's it. The vertigo can be from like cerebellar tract affection. So the only one that will tell me for sure it's a cranial nerve affection is the difficulty swallowing itself. Now I wanted to ask you a question. Is it problem in the left bica or the right bica? What do you think, guys? Left bica or the right bica? So amazing. We said what? We said any problem in the brain is contralateral except the cranial nerves, the face, and the cerebellum would be ipsilateral. So here his body is in the left. Sorry, where his body is on the right, right? Right side of the trunk and extremity. So the problem would be contralateral. The problem would be on the left. So this is problem on the left posterior inferior cerebral artery. Okay. So that's the thing. So the reason I didn't like care that much yet about the sympathetic symptoms, because if there is ptosis and the meiosis and anhydrosis, this just will tell you it's like Horner syndrome and it's a sympathetic nervous system affection. I know that the sympathetic itself, right, can be like lateral, But this doesn't tell me, is it lateral medulla, or is it lateral bones, or is it like lateral like midbrain itself? And that's why I always tell students, focus on the cranial nerves affected, do not focus on the other like tracts, or like the sympathetic, or the cerebellum, or the spinothalamic, or these things, because they will just tell you lateral or medial. They will not tell you the specific location itself. So here the problem is in the right side of the body, so it would be affecting the left side of the brainstem itself, psi. So the problem here would be on the left posterior inferior cerebral artery. Okay. Now let's see another question and try to answer it. Okay. So here again, these questions are very long, and you will see this on the exam. These questions will be pretty long. So, a 62-year-old man comes to the emergency with sudden onset dizziness and difficulty swallowing that began 2 hours ago. He says the room feels like it's spinning and he has several episodes of vomiting. He also reports that his voice sounds different and that he keeps coughing when trying to drink. So, one thing I need to focus here is the coughing part. So, let's continue. He has smoked 1 pack of cigarettes for 35 years, drink 1 to 2 beers on weekends. His father died at 68 of heart problems. All of this is not important. Just skip it. Blah, blah, blah. The vitals are fine. A little bit of hypertension. Pulse is fine. Respiratory rate is fine. Oxygen fine. The patient is alert. I don't care about everything here. All of this you can literally skip without affecting the question, because all of this are just things they have to say to make the stem a little bit long, but it doesn't give you any important fact. What you need to focus on, guys, are the keywords. So let's go into what actually matters. So they told you there is ptosis meiosis, so that's another Horner syndrome. That's fine. It tells you it's a sympathetic problem. Pain break and temperature is decreased on the left side of the face and the right arm and leg. So here is the catch, that there is another crossed lesion. Can you see? It may sound obvious for you guys, but if you see an actual question like this and it's pretty long, you can miss this specific detail because the question itself is too long, so you will not focus that much. And that's why I need you, while you answer neuroanatomy, is to be intentional, to answer it with focus. Okay? So we know it's the left side of the face and the right side of the body. So I know it's a brainstem problem. Okay? Now, what's the problem here, Faizan? That's another one. I will tell you something. So, this person is having coughing and difficulty swallowing. Another coughing and difficulty swallowing. So, which cranial nerves would it be? That's the thing. I don't want you to focus on the dizziness. I don't want you to focus on the like the sympathetic. Okay, these things will not give you the specific location. That's the thing. Okay, so the coughing problem with coughing, it means maybe there is problem with the gag reflex, right? And that's it. Amazing. Difficulty swallowing. So this would be 9, 10, 11. I draw like I always do this. So I know now it's like brainstem problem. I know 9, 10, 11. I will draw it in the exam like this very fast. 3, 4, and then 5, 6, 7, 8, then 9, 10, 11, 12. That's 9, 10, 11 here. Then it's lateral medulla, and that's it. So that's the lateral medulla. Now, it's affecting the body where? It's affecting the body on the right. So it's a problem on the left. Because we said the body will be contralateral. Everything is contralateral except the cranial nerves will be ipsilateral and the cerebellum. So it will just be the left lateral medulla itself, guys. Okay. So can you see like how like it's easy to answer these questions no matter how difficult they are and how weird they will look like, just to filter what actually matters on the exam. Okay, they can't go outside of this. Okay, so I don't want you to go into like, oh, the spinothalamic tract is lateral, the sympathetic tract is lateral, and to like overwhelm yourself with which tracts or lateral, which tracts are medial, because I don't think they will be useful. Like, sure, I can tell you this, guys. So what I can tell you is this. Let me do this here. Yep. So anything with M is medial, guys. The medial lemniscus is medial. This is important for proprioception and vibration. The motor is medial. The motor cranial nerves are medial. Can you see? 3, 4, and 6 are important for the eye. This is the oculomotor, the trochlear, and the abducens. 12 is important for the tongue movement. So cranial nerves that are motor are medial. Okay? And the medial longitudinal fasciculi, which is important to move the eye, is also medial. So anything with M is medial. Anything with S is on the side. So the spinothalamic tract, which is for the pain and temperature, is in the side. Sympathetic tract is on the side, lateral. Okay. Spinocerebellar, the cerebellar one. Um, the sympathetic or the sensory cranial nerves and the mixed cranial nerves are also lateral. Isn't like 5, 7, and 8 are sensory and mixed? Isn't 9, 10, 11 sensory and mixed? These are lateral. So sure, we can know which ones are medial, which ones are lateral. But you only actually truly need only the cranial nerves to answer the brainstem lesion problems. Okay? So that's for the brainstem lesion problems, guys. By the way, like we'll just like and that's very important. We'll just try to take as much as we can. So if we go over the 1 hour, try just to bear with me, guys. I just want to make this neuroanatomy crystal clear for you. Okay? So we'll not be leaving like until we finish at least most of the important neuroanatomy. So that's like regarding the brainstem, guys. And after I teach each structure, I always love to do a recap because always repetition makes perfect. Okay. If you need to like get a very high score or to do something very well, it doesn't matter if you have the skills to do it or not. Just repetition will get you up there. There is no something called like plateau or something like that. Like, and that's the way I got like a good score on like the step two. That's the way my students like can get from like scoring 50 on the NBMEs to 70 is just to do more questions. I don't want you to be upset. And then to try, and this is something I know it's a side thing, but I see students like are stuck on specific system or stuck on a specific score. And then they start trying fancy things like, oh, let me see this specific resource, or let me watch this specific whatever, or let me do this specific plan. No, guys, if you are stuck on something, the solution would be very easy. Just like do more questions on it, okay? And that's it. I understand like some of students may need like tutoring in this part or like more explanation, like watching a specific videos like boards and beyonds and basoma. But most of the time all of this sounds good, but unless you like actually practice and do more questions, like it wouldn't be that helpful. You always need to do more questions, and it's very important. Now that's for the brainstem. So we said here the cortex is anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, right? And we said anterior cerebral artery would be the legs. Middle cerebral artery will be the head and the hand. Head, hand. Okay. And then we will know the posterior cerebral artery will be vision loss, something called the contralateral homonymous hemianopsia with macular sparing. Okay. Then we know the internal capsule, and the thalamus will be usually one half of the body at the same lesion like this, the same side. And if it's a motor, it's internal capsule. If it's a sensory, it's thalamus. Both of them will be supplied by an artery called lenticulostriate artery. And this one can be affected by hypertension. And it can affect them by two ways. Either by blood rupture or blood bleeding, so something called Charcot-Bouchard microaneurysm, or by ischemia, something like lacunar infarction. Okay, guys? And then another thing is the brainstem. We say it first, ask yourself, is this crossed lesion or not? Then try to localize which cranial nerves is affected. Then you would need to know which artery is being supplying this specific part, as simple as it is. Now we discussed these things. I wanted to go with you through the circle of Willis, just as you can ask about it. So the circle of Willis here may sound very confusing, right? But let's draw it like this. So that's like, or let me change the color here, guys. So that's the brain. If you know that's the brain, it will be pretty easy to know the arteries that supplying the brain, right? So the artery anterior here would just be the anterior cerebral artery. So this one is easy, anterior cerebral artery. The artery in the middle, middle cerebral artery. Very easy, and we know now what do they supply. And then the artery posterior will be the posterior cerebral artery here. Now, the arteries that communicate between the middle and the posterior is called the communicating artery, posterior communicating. And the arteries that communicate between the two anteriors are called the anterior communicating artery. And that's it. Okay? So that's for the anterior circle of Willis because we said this is the brain. So that's literally, where did we do it here? That's literally the circle of Willis that we draw here. Okay? Then, after the brain, we have, let's skip the thalamus and the internal capsule because these are the lenticular striate. It's not from the circle of Willis. And then let's go into the brainstem. We said this is the brainstem, right? Remember, we said the brainstem is the midbrain, then bones, then the medulla, right? We said the midbrain is what? So midbrain is here, is posterior cerebral artery. So it makes sense. The posterior cerebral artery is here, okay? Then we said the bones are what? We said the bones are the basilar artery in the middle and the anterior inferior cerebral artery at the lateral. Here, the anterior inferior cerebral artery is here, okay? And the basilar artery is here, middle. And then the medulla is where? The medulla is here. We said lateral medulla will be posterior inferior cerebral artery, and then medial medulla will be the anterior spinal artery here. So just to draw it like this, so you can visualize. I don't want you to memorize the circle of Willis, then memorize the structures, and then to dissociate them from each other. No, literally, if you draw the structures into the circle of Willis, they will make sense for you. Okay? So this is the circle of Willis, and these are the structures here. Very easy, guys. Okay? Now, one thing is that this is the brain. So this part here is literally the same as this part. That's the same as the brain here. Anterior cerebral artery, middle cerebral artery, posterior cerebral artery. I will prove this for you. I will prove this for you. So here, what's here anterior? Anterior cerebral artery. What's here middle? Middle cerebral artery. And what's here posterior? Posterior cerebral artery. And it makes sense because we said anterior cerebral artery will supply the legs. It makes sense. And we said middle cerebral artery supplies the arm and the face. So can you see it makes sense on the homunculus? And it's pretty easy now since we can visualize these things. Okay. Now you will ask me a question. So I know that the anterior cerebral artery supplies the legs. So if you have problem in the anterior cerebral artery, would you get like legs problem? I know, but would you get it motor or sensory? This does not depend on the artery. This depends on the location of the lesion, of the specific lesion in the cortex. Is it pre-central or is it post-central? Okay, guys, so here, if this is the brain, we have something called the central gyrus. Pre-central is usually frontal to the central gyrus. Post-central is after the central gyrus, so it's posterior. Okay, so pre-central, the frontal to the central gyrus, is usually motor. Post-central is usually sensory. Okay, and here is how I remember it. So please remember, post with S is sensory. It's a somatosensory cortex, but the pre-central is the motor. Okay, guys. So the post-central is the sensory. The pre-central is the motor. That's the best way I approach this one. Okay. So let's read this and we'll try to figure out with each other. Okay. Okay. Let's read here, guys. And I am trying to like look at the chat also, okay? And like if you have like questions while I am going through it with each other, like we'll also try to like address it, okay? And that's true also like Faizan is that like the macula itself is not supplied by the posterior cerebral artery. That's why if you have like posterior cerebral artery lesion, like the macula will be spared. Not because it's not supplied, but because it received double blood supply from the posterior cerebral artery and from the from the middle cerebral artery also. Let's answer these questions, guys. I need to answer this question with you. And let's try to like address it with each other. Okay, let's go. So a 65-year-old man is brought to the emergency because of sudden onset of numbness in his right hand and arm that began 3 hours ago. Numbness in the right hand and arm. He has a history of hypertension and the permanent atrial fibrillation. I just want you to answer this question for me, guys. If there is numbness of the right hand and arm, which artery will be affected? And the left or right? What do you think? Amazing. Hand and arm, hand and head, right? And arm would be the middle cerebral artery. And it's on the right yad. So we said everything in the brain is contralateral except cranial nerves or cerebellum is ipsilateral, guys. Remember this. Remember this, Elena. So here it's right hand and arm. So it would be affecting the left middle cerebral artery. Okay. These things are always confusing. So that just to follow this rule. Okay. So it would be the left middle cerebral artery here, guys. So now we know the artery, but they are not asking about the artery. So let's continue and see. He has a history of hypertension and permanent atrial fibrillation, and he admits to being non-compliant with his medications, including like his prescribed anticoagulants. On physical exams, there is significant decreased sensation to light touch, pinprick, and the vibration over the right hand and right forearm extending to the elbow. Sensation is completely intact over the right side of the face and the right lower extremity. Motor is fine, everything is fine. Can you see all of this is useless? We didn't really use any of that. Literally, you can just delete this and it wouldn't affect like the answer because we already know the problem. We know it's a problem in the hand and arm, okay? And we know it's right middle cerebral artery. Now they are asking me like, where? Where in the homunculus? So first, where is the hand and the arm? Is it like lateral or medial? And is it post or pre? That's the thing. What do you think, guys? And is it left or right? So we take it one by one, and I always love to answer it with the ones I know for a fact. But I will give you like few seconds, guys, and try like to answer it with me. Okay. So some of us are saying like it's maybe post central, maybe right. Okay. So I will tell you something, guys. I will give you a fact. Do you remember our way to remember it? Is that this is sensory, right? Numbness is sensation. So which one is sensory? The one that has like R is sensory or motor, and the one that has S is sensory or motor. That's the thing. That's how I approach it, right? Perfect, perfect. Amazing, amazing, yeah, amazing, guys. So how do I approach this question? Is at first I know it's in the hand and arm. So I know from the homunculus, let's see the homunculus here, it would be like in this part, lateral, not medial, because medial is anterior cerebral artery. So it's lateral, middle cerebral artery. Okay. And another thing is that I know it's on the left because it's affecting the right body. Last thing is to know is it post central or pre-central? Post is sensory, pre-R is motor. That's how I remember it, guys. Okay, that's how I remember it. Now another question for us guys here. After this question, we will go into what is it? The brainstem lesions. The brainstem lesions. Okay. This question is pretty hard. I am just bringing it so we can address like these specific facts. So a 68-year-old man is brought to the emergency by his wife because of the sudden onset of uncontrollable movement. His wife states that while they were eating breakfast, his left arm suddenly began flailing wildly, okay, nearly hitting her, and his left leg began kicking out uncontrollably. He has a history of hypertension and diabetes and a smoker. Blood pressure is 170. Okay. On physical exam, the patient is alert and oriented, continuous large amplitude, non-rhythmic, flinging movements on the left upper extremity and lower extremities. Strength is 5 out of 5, and sensation is intact, and they're asking which of the following structures is most likely responsible for this. It's a very hard question. So they are telling me here that this person is having like uncontrollable movement and the arms is suddenly beginning flailing wildly. And I know some of you may think it's Korea or Huntington, but Huntington wouldn't cause this, guys. Huntington doesn't cause like increased movement like or very like uncontrollable movement suddenly like this. Because Huntington is a neurodegenerative disorder, right? It's inherited autosomal dominant, and it starts slowly. Okay, so it wouldn't go sudden onset, and it's not like, oh, like rapid large amplitude like this. Okay, so it wouldn't be Huntington, and the answer would not be the caudate nucleus, because Huntington affects the caudate nucleus, which would be the wrong answer here. So it's not Huntington. Okay, so what is this? Okay, I will give you like options and tell me, guys. Like this is like rising movements and like, oh, sorry, this like flailing movement, Faizan, and all of this other stuff. What do you think, guys? And guys, I am also like recording, by the way. I am recording the video if you like could need the record afterwards. Okay. So what do you think here? Yes. This person is having hemipalismus, guys. Extremely important. Hemipalismus itself. Okay? Hemipalismus itself. Okay? Which is problem in the subthalamic nuclei. Amazing, guys. This is called the hemipalismus, this flailing movement, and it's a problem in the subthalamic nuclei. Now, it's pretty hard to figure out where is the subthalamus here, but if like, let me show you this. So if that's like the thalamus here, the subthalamic is like is below it. It's E. Okay, guys. So it's like a pretty hard question in general. Okay. But what I need you like amazing guy, what I need you guys like to figure out is just like that if there is flailing abnormal movement, that would be the subthalamic nuclei. Now I wanted to ask you a question, guys. It's this problem is usually on the left side of the body. So which subthalamic nuclei is most likely affected, right or left? This question sounds weird because it's the first time I ask about it, but it's really not, because if we apply the rule, everything is contralateral, okay, except the cerebellum and the cranial nerves. So this would be on the right. Amazing. It's affecting the left, so it would be on the right, guys. Amazing. So that would be the subthalamic nuclei. Now, if I open this picture for you guys here, so that's the thalamus itself. The thalamus will cause just sensory loss of one half of the body. It makes sense because we have something called the spinothalamic tract. It's pain and temperature. Okay. And then the internal capsule is here. Can you see? The internal capsule is here. This is the motor loss, especially the posterior limb of the internal capsule. And all of these things, guys, are supplied by this lenticulostriate artery we talked about. It supplies all the deep organs like that. Lenticulostriate artery. Okay. Then we have the caudate. This one is usually the one affected in Huntington disease. In Huntington disease. Then we have the substantia nigra is below the subthalamus. It's usually in the midbrain. This is the midbrain, something called the pars compacta, and it would be affected in Parkinson. Amazing. Okay. The globus pallidus and the putamen is usually not important. They are just important to coordinate movement, but they will not ask about them. Okay. And I almost forgot, but we have the hippocampus here. Do you know what's the function of the hippocampus? Hippocampus, guys. And what specific, Faizan? What do you think, guys? Hippocampus. Hippocampus. More than fear, more than temperature, more than behavior. Memory is the most important. It's very important to make memory. And if you have problem in the hippocampus, you will get anterograde amnesia. Hippocampus is very important to remember, to gain memory and to form memory. And it's the most common organ to be affected if you have hypoxia. This is something they ask about. If there is hypoxia, which organ is most likely to be affected? It would be the hippocampus. And it's important for making new memories, guys. Okay? Amazing. Amazing. Perfect. So, if like the rule is everything is contralateral in the brain, except cerebellum and the cranial nerves are ipsilateral. Okay? This is in the brain, cerebrum. This is in the brainstem. This is in the thalamus, the internal capsule, and all the structures. Okay? Now, the spinal cord has different rule. So we will discuss the spinal cord with each other, guys. Okay? Now, the way I love to teach the spinal cord, I don't love to teach it in like this, but I love to teach it in a whiteboard first, guys. Okay? And we will try to make sense out of it. So that's the spinal cord here. And I want you to only know like 3 or 4 tracts. We will discuss the normal physiology of the spinal cord first. And after we discuss the normal physiology of the spinal cord, we will try to address the pathology itself. Okay? So that's the spinal cord, guys. And I want you to know first the normal tracts. So this tract here is called the dorsal column tract. Okay? Dorsal column tract. And what I need you to know about the dorsal column tract is that it's important in the vibration and the proprioception. Vibration and the proprioception and the balance and the fine touch also. Good, good, good. And we have in this dorsal column tract, it's made from like 2 tracts, guys. It has a tract called gracilis and a tract called coniate. So coniate and gracilis. I know it sounds too much, but the way I remember it is that gracilis will touch gracilis, ground. So gracilis will usually innervate the legs. Coniate is next to your shoulder. Coniate, it's next to the shoulder. So it will affect the arm and the upper extremities. So dorsal column is made from 2 tracts, gracilis and coniate. Gracilis is middle, ground, legs, and coniate is usually the arms itself. Okay. Now, the other thing that I wanted like to discuss with you guys is the other tracts, which is usually, let me draw it here, the corticospinal tract here. The corticospinal tract in yellow. This corticospinal tract, guys, it makes sense. Look at the name, from the cortex to the spine. So you think about moving, so it goes from the cortico to the spine, so you move your muscle. So the corticospinal tract is important for the motor. And it's actually an upper motor neuron. It's an upper motor neuron. So the corticospinal tract is motor, guys, and it's an upper motor neuron. Okay? And then this corticospinal tract will travel, and will go to the anterior horn. And this anterior horn will supply the muscle. It will supply the muscle, guys. Okay? And the anterior horn itself is a lower motor neuron. And a very important question a student asked me is how to differentiate upper motor neuron signs from lower motor neuron signs. Upper motor, everything is up, right? So upper motor, everything goes up. So you will have hyperreflexia. You will have hypertonia. Okay? You will have spasticity. You will have the plantar reflex to go up. So the toes will go up. The toes go up, upward plantar reflex. Okay? So you will have positive Babinski sign and upward plantar reflex. Everything goes up in upper motor neuron. So if you affect the corticospinal tract, you will have upper motor neuron. Okay? Now, if you affect the anterior horn, on the other hand, guys, you will start to get a lower motor neuron. And in lower motor neuron, everything goes down. So you will have hyporeflexia. You will have flaccidity. You will have hypotonia. And you will have a very important keyword. This keyword is called fasciculations. Fasciculations. Once I hear the word fasciculations, it's a small twitching of the muscle. This is a lower motor neuron, especially the anterior horn itself. And also the muscle itself will get down. So you will have muscle atrophy. So everything go down. That's a lower motor neuron. So now we know the corticospinal, now we know the anterior horn, and also now we know the dorsal column itself. Okay, guys? Now these tracts here, they go like they like, for example, the dorsal column go into the brain, and it will be called in the brain the medial lemniscus. In the brain, we call the dorsal column the medial lemniscus. And we know that also the corticospinal tract usually arrive from the brain. And these tracts, guys, are ipsilateral. They are ipsilateral. So if you affect the corticospinal tract on the left, so let's say this is the left side. Let's visualize it. We don't need to remember it. Let's say we are affecting literally the corticospinal tract on the left. Then you will affect the body or the muscle on the left also. Can you see? We didn't even cross, right? We didn't even cross. So ipsilateral, dorsal column or motor will be ipsilateral, guys. Okay. Now, the last tract we need to discuss is a tract called the spinothalamic tract. This tract is here, spinothalamic. Okay. Now, this tract, guys, usually go up for one or two like vertebrae, and then it will cross. And because of this, if you affect the spinothalamic tract, guys, it will cause contralateral problem below the lesion. So if you affect it on the left, it will cause contralateral problem on the right below the lesion because it crosses. Does it make sense, guys? Imagine you affect this part. So it will cause contralateral problem below the lesion, right? So the rule I want you to memorize, guys, and that's a very important rule, is that in the spinal cord, any lesion or every lesion is ipsilateral, either dorsal column, motor, even the spinothalamic at the same side of the lesion or the same level of the lesion. The only exception is usually pain and the temperature. Below the lesion is contralateral. Can you see how easy it is? You don't even need to remember each one individually. Every lesion is ipsilateral. So corticospinal on the left affects the left. Anterior horn on the left affects the left. Dorsal column on the left affects the left. Spinothalamic on the left at the same side affects the left. Below the lesion affects the right. That's the only exception. Below the lesion, spinothalamic or pain and temperature. Because this is spinothalamic carries the pain and the temperature, guys. It makes sense. It's called the spinothalamic. So it goes from the spine to the thalamus. And we said thalamus is sensory. So spinothalamic will carry the pain and the temperature. Okay, guys? So now we know the normal tracts. Now we know the normal tracts. The second thing we need to figure out is which disease affect which. Okay? So we will go through them here and we will go over these diseases, Sylvester. Don't worry. So the first disease I want to go over is tabes dorsalis. What is tabes dorsalis? Tabes dorsalis is syphilis, neurosyphilis. Remember, syphilis has three stages. The first stage is bearless ulcer. The second stage is rash in the palms and the soles. The third stage is neurosyphilis, right? And it can also cause thoracic artery aneurysm and something called gamma. So this is tabes dorsalis, syphilis. Syphilis causes the dorsal column affection, guys. And that's why it will cause like problem in vibration and the proprioception and the balance. So it will cause ataxia, okay? It will also cause severe lower back pain. I remember it affects the dorsal column. Dorsal column is near your back, so it will cause severe lower back pain, okay? And it will cause something called argyle Robertson pupil, which is very important. Do you know, guys, what is argyle Robertson pupil? Something called argyle Robertson pupil. Argyle Robertson pupil. What do you think? Most of the time, Abdullah, it's in the tertiary syphilis. Tertiary syphilis most of the time. Yes. Argyle Robertson pupil, guys, is usually an eye that accommodate but does not react. It has normal accommodation reflex, but it doesn't react to light. Once you see this Argyle Robertson pupil, you start to think about neurosyphilis and you start to think about tabes dorsalis. Okay, so that's for tabes dorsalis effect. Only affects the dorsal column. Okay. Then we have a disease called subacute combined degeneration. From the name, it's called subacute because it happens like a little bit progressively, combined because it affects the dorsal column and also the corticospinal tract combined with each other, the dorsal column and the lateral corticospinal tract. And it will happen usually from a specific vitamin deficiency, which is vitamin B12. Remember, guys, something very important I need you to know about vitamin B12 is that we have B12 here and we have folate. Both of them will cause hypersegmented neutrophils. That's very important. Do you know why? Both of them will cause megaloblastic anemia. Do you know why, guys? Why B12 and the folate can cause hypersegmented neutrophils and the megaloblastic anemia? Yes. Because usually, guys, amazing, you have a big cell, you have a very big cell, and you need usually to, for this big cell to proliferate it, to mitosis, for mitosis to happen. And because B12 and folate, if they are deficient, you will not be able to make pyrimidine, which is important for the DNA. If you cannot make pyrimidine, which is important for the DNA, the cell will not be able to divide. So the cell will be very large. So if it's a neutrophil, it will be very large. It will be hypersegmented. Okay? If it's a blood vessel or blood cell, sorry, it will be very large. It will be megaloblastic, MCV more than 100. Okay, guys? And B12 and the folate also, both of them cause increase in the homocysteine level. The only difference is that B12 also cause increase in methylmalonyl-CoA and the nerve problem. But B9 cause normal methylmalonyl-CoA and no nerve affection. So both of them increase homocysteine, both of them cause megaloblastic anemia, both of them cause hypersegmented neutrophils. But B12, I remember B12 1, 2. So it increased two things. It increased homocysteine and the methylmalonyl-CoA. Okay? Folate only affect one thing. So that's for B12 and B9. So if you have B12 deficiency, you can have affection of the dorsal column. So you'll have problem in vibration and the proprioception. You will also affect the corticospinal. So you will get upper motor neuron lesion. So you will start to get like hyperreflexia, hypertonia, things like this. Okay. Now some students know that upper motor neurons can cause hyperreflexia, but they don't know what's the normal reflex. So the normal reflex, guys, is +2. So if they tell you reflexes are +3, that's a hyperreflexia. If they tell you reflexes are +1, that's a hyporeflexia. So please remember the normal reflex range, it's +2. So if it's +3, it's a hyper. If it's +1, it's hypo. Okay. Now, another disease I want you to know is usually amyotrophic lateral sclerosis. This one is very high yield, extremely high yield. Okay. Amyotrophic lateral sclerosis affects the corticospinal, guys, and at the same time affects the anterior horn. So would it cause upper motor neuron or lower motor neuron? What do you think? Would it then cause upper motor neuron or lower motor neuron lesion? I always diagnose it on the exam with both of them. I will see both of them, both the signs, guys, both the signs, Nathania, amazing Faisal, both signs, Helena. So when I see like +3 reflex, so hyperreflexia, and the hypotonia or muscle atrophy, or like fasciculations mixed, I always know it's amyotrophic lateral sclerosis. But I have a very important question. Can it cause sensory loss? Can it cause sensory loss, Aya? Like that's a very important question. Can it cause sensory loss? Even like a little, even 1% of people? Yeah. Never sensory. Please do not see on the exam a person with sensory loss and pick it and tell me, oh, Karim, I thought it's an atypical question and they bought sensory loss for us to confuse us. No, if you see sensory loss, never pick it. It's only pure motor, upper and lower motor neuron lesions. That's amyotrophic lateral sclerosis, guys. Okay. Then spinal muscular dystrophy or spinal muscular atrophy affects the anterior horn only. So it will cause lower motor neuron lesion only. But what I need you to know is the keyword. Please know this keyword and you will answer it. The person will have tongue fasciculations. You will see a kid with tongue fasciculations on the tongue. If I see tongue fasciculations, that's a spinal muscular atrophy. Some students tell me I always confuse the spinal muscular atrophy from amyotrophic lateral sclerosis. ALS or amyotrophic lateral sclerosis affect all the males, guys, and it's mixed. Spinal muscular atrophy will usually affect kids, children, and it will cause like floppy baby, and it will cause tongue fasciculations, only lower motor neurons, and affect kids. So one of them affect kids, the other ones affect adults. Okay, guys? Now, anterior spinal artery occlusion. What would it cause? So anterior spinal artery supplies the anterior spine. Posterior spinal artery supplies the posterior spine, right? So if you have posterior spinal artery occlusion, you will have problem in the dorsal column, right? It will be similar to tabes dorsalis. So for example here, tabes dorsalis, we can put also posterior spinal artery occlusion. It can cause the same thing. It can affect the dorsal column. We can also put vitamin E deficiency, guys. Vitamin E can also affect the dorsal column. Okay, so we can put like these 3 things can affect the dorsal column. But on the other hand, anterior spinal artery will affect the anterior horn, the corticospinal, spinothalamic. So you will get problem in everything except the dorsal column. So you will not get problem in the vibration or the proprioception at all. Okay, you will just get problems like in the corticospinal, in the anterior horn, and on the spinothalamic tract, but you will never have vibration and the proprioception affection. Okay. Then let's see this one. This one is called the central cord syndrome, or there is another disease called syringomyelia. This disease affects the spinal cord like this. Okay. And when it affects the spinal cord like this, it can affect the pain and the temperature because we say pain and the temperature cross like that. I don't care about this. What I care about is how would you diagnose it actually on the exam, guys? How would you diagnose it on the exam? So here is how. They will tell you female because usually syringomyelia happens in females, and they will tell you she is having problems in the upper extremities like this. She have, for example, problem pain and temperature in the upper extremities. Sometimes also motor affection. Okay, and this is syringomyelia, and the way they most commonly describe it, they will tell you the female is like always burning her hand while she is cooking. So she have problem feeling things with his hands. That would be syringomyelia, guys. It affects the central spinal cord, and it causes like jacket-like distribution. It feels like the female is wearing a jacket. She cannot feel anything in the upper extremities. Okay, guys? Then I left the hardest for the end. But yes, yes, Iyad, of course. Like always ask me, man. So we say it like that the pain and the temperature or the spinothalamic tract will usually cross here, right? So if you have central cord syndrome, you will affect where the spinothalamic tract cross, especially the spinothalamic tract in the upper limb. And that's why central cord syndrome or syringomyelia will affect the spinothalamic tract on the upper limb. So you will have like a female with jacket-like distribution in the upper limb like this. Okay, that's like syringomyelia itself. Syringomyelia itself, Faisal. Okay. Now, let's go to the ones that confuse people. Brown-Sequard syndrome. What is Brown-Sequard syndrome? It's one half of the spinal cord affected like this, semi-half. Is it realistic? You don't see it really in clinical life. It's very rare. But they ask about it like very rare. They ask about it really for us to know neuroanatomy, right? For us to know neuroanatomy. So here is how I would like describe it with you guys. Okay. So let's say you have Brown-Sequard syndrome on the right. What would you get? They will tell you this. What would you get? Now, students start to be confused. They will tell them like, would you get pain and temperature in the ipsilateral, like dorsal column ipsilateral? So follow the rule we talked about. If you affect the right, everything will be ipsilateral except pain and temperature. Below the lesion will be contralateral. So for example, if you have Brown-Sequard syndrome on the T8, what would you get on the right? First, motor. You will get motor loss in the right. Then, vibration and the proprioception. You will get vibration and the proprioception loss on the right. Then the only thing that will need an effort from us is the pain and the temperature. Pain and the temperature will still be on the right at the level of the lesion, at T8. Then at T10, for example, the pain and temperature will be on the left. So the only thing that's different is the pain and temperature. Below the lesion, it would be contralateral. That's literally the only difference. Can you see? Without having to memorize all of them, Jai. Okay? So that's regarding the brain, like the spinal cord, guys. That's regarding the spinal cord. And let's answer spinal cord questions with each other and let's try to figure it out. So let's see here. A 50-year-old man comes to the physician because of a 6 month history of progressive weakness. He initially noticed difficulty turning keys and buttoning his shirts, but over the past like 2 months, he has also experienced frequent tripping and stiffness in the legs. He has no history of serious illness. Vital signs are within the normal limit. Neurological exam shows. So what I can you see while I'm reading? You feel lost, right? Why? Because I am not reading with intention. What should be my intention here? My intention should be figuring out what are the tracts they are talking about. So I focus while I'm reading to figure out if there is a tract they are talking about or not. So here there is progressive weakness. So I know it's a motor tract. Okay. He has also experienced frequent tripping and stiffness. So I know from this that's an upper motor neuron lesion. So it's a corticospinal tract maybe. He has also no history of serious illness. Vital signs are within the normal limits. There is atrophy. So that's a lower motor neuron lesion. So there is upper motor, there is also lower motor, atrophy of the muscle. There is frequent irregular muscle twitches. That's fasciculations. That's another lower motor, guys. So there is two lower motor signs and one upper motor sign. Muscle tone is increased, upper motor. Deep tendon reflex are +1, lower motor, and +4, upper motor. Plantar stimulation yields bilateral extensor response. That means it's positive Babinski sign, upper motor. Sensation to pain break, temperature, vibration is intact. No sensory affection. No sensory affection. So what do you think here, guys? A schematic cross-section of the cervical spinal cord is provided below. Degeneration of which of the following structures best explains this patient's like physical examination findings. So what do you think here, guys? And I will show you they want two tracts to be affected. What are the two tracts that are affected? And what do you think is the diagnosis, guys? So there is mixed upper and lower. So what do you think is the two tracts being affected here? Mixed upper and lower. What are the two tracts being affected? So what do you think? Okay, Yasser, Yad, amazing. So we know first that let's draw it here. This is the dorsal column, right, guys? And we know that this is the corticospinal, right, yet? Corticospinal. And we know that that's the anterior horn, anterior horn. So that's the corticospinal, and that's the anterior horn. And we know that this is the spinothalamic, spinothalamic. So the spinothalamic is here, the anterior horn is here, corticospinal here, dorsal column is here. What is this like long one I am drawing was like green? I don't even know. It's spinocerebellar. It's not important. So you'll always give some few like tracts here and there to confuse you. So I focus on what matters. I know this person is having a mixed upper and lower motor neuron lesions. So I know it's amyotrophic lateral sclerosis. So I know I am affecting the corticospinal tract and the anterior horn, both of them, the corticospinal tract and the anterior horn, guys, right? That's the things affected in the amyotrophic lateral sclerosis part. So probably it would be B and E, right? And that's very important. So the corticospinal tract, why MK? Because this person is having upper motor neuron lesion, right? Upper motor neuron lesion. There is +4 reflexes. There is a stiffness. Why anterior horn? Because this person is having lower motor neuron lesion, like atrophy, like +1 reflex. And what's the name of the disease? That's amyotrophic lateral sclerosis that affect middle-aged males, right? Amazing. So that would be like I almost forgot like what did we answer? Okay, and that would be like the amyotrophic lateral sclerosis itself. And I wanted to ask you like a hard question, guys. What do you think is the treatment for amyotrophic lateral sclerosis? What do you think, Faisal? What do you think, guys? BMT, that's very new, yes, sir, yes, and riluzole. That's what they ask on the exam. Riluzole, okay? Riluzole, guys. Riluzole. It's a step two question, but why not? Like to also to prepare for step two, okay? Now, let's see another question, guys. So a 42-year-old man comes to the physician because of 4 months history of progressive clumsiness, difficulty walking, particularly at night or in like poorly lit rooms. He also reports intermittent sharp shooting pains in his legs. His medical history is notable for unprotected intercourse with multiple sexual partners. And again, I am reading, but I am not reading with intention. So let's read with intention. So this person is having like clumsiness and difficulty walking. So probably some kind of ataxia. And he also have shooting pains in the legs, severe back pain and severe leg pain, and unprotected sexual intercourse. That's like maybe a sexually transmitted disease or maybe something like that. He recalls having a painless ulcer on the penis several years ago that healed spontaneously without treatment he had. And the vitals are within the normal limit. Neurological examination shows normal muscle bulk and strength in all the extremities. And the pinprick and temperature sensation are intact bilaterally. Vibratory and position sensation are decreased in the bilateral lower extremities, and deep tendon reflexes are absent at the knees and ankles. When asked to stand with his feet together, his eye closed. I don't know if you can figure out what sign is this. When he stands with his feet together and the eyes closed, he sways like and loses his balance. That's called the Romberg sign, guys. Amazing. Romberg sign happens when you close like the eyes and you put like the feet together. You cannot maintain balance. It happens usually when the dorsal column has been affected. Amazing. And they are asking like which of the following like labeled regions explain the finding. Amazing. So what do you think here, guys? So which one has been affected here? So few things we need to know, right? Amazing. Perfect. Perfect. So from this person like ataxia, Romberg sign, I know that this is problem in the dorsal column itself. And I know from the history of sexual history and from the painless ulcer, that's usually syphilis. So I know that would be tabes dorsalis or neurosyphilis that happens more commonly in tertiary syphilis. Okay, so I know that the ulcer here will be the dorsal column, which is A. And in order to treat it, you need to give the person intravenous penicillin. Even if they have allergy to penicillin, you still need to desensitize them from penicillin and give them penicillin, guys. Okay? Desensitize them and give them penicillin. Okay? Now, a last question, guys, here. So, this one, they said a person is brought to the emergency department after repeatedly bumping his walls into the right side while walking down the hallway. He has a history of hypertension and hyperlipidemia and atrial fibrillation, and he is not currently taking like anticoagulants, and his temperature is 37, and the pulse is 96, irregularly irregular. So once they say irregularly irregular, I know it's an AFib that's uncontrolled, right? And then his blood pressure is 148. Physical exam shows no motor weakness or sensory defects, and deep tendon reflexes are +2 and symmetric. A CT angiogram of the head is performed to evaluate the cerebral vasculature, and they are asking occlusion of the artery indicated by the arrow in the provided image is most likely associated with which of the following neurological defect. So that's the image here, and they're asking occlusion of this artery will cause what? So which artery is this? Huh? It's very hard to imagine it, right? Very hard to imagine it. You are very close, Iyad, very close. Yes. Remember, guys, what did we say? First, this is the cerebrum here. So that's the anterior like cerebral artery, middle cerebral artery, and what would then be this? Yes, posterior cerebral artery, guys. Then like this is like the and also the like the midbrain is here. The midbrain is also supplied by the posterior cerebral artery, and the posterior cerebral artery will also do another thing. And then we have like the bones. The bones will be basilar artery and the ICA. And then we have the medulla. The medulla will be bica here. That's bica. And anterior spinal artery here. Anterior spinal artery here. Okay. So we know that this is the posterior cerebral artery. That's the posterior cerebral artery. It supplies the midbrain, but it also do another thing. What do you think, guys? What else it can do, or it can does? Would it be contralateral hemiparesis affecting the lower extremities, or contralateral hemiparesis affecting the upper extremity and face, or homonymous hemianopsia with macular sparing, or Horner syndrome and loss of pain and temperature on the face, or quadriplegia with preserved vertical eye movement? What do you think? Okay, okay. Perfect, guys. So that's the posterior cerebral artery. We said it supplies the middle midbrain and it also supplies the eyes. The eyes. I don't know if you have heard this or not, but there was a saying long time ago, like all the people used to say this, is do not hit people on the back of their head. Of course, do not hit people anyway, but they always used to say do not hit people in the back of their head because they can go blind if you do this. So that helped me remember that the visual cortex remain in the posterior cortex and posterior cerebral artery will supply the eyes. So the person will have contralateral homonymous hemianopsia with macular sparing if you damage the posterior cerebral artery. Now, can I ask you a few questions? How about if I damage the basilar artery? How about if the person is having rapid correction of hyponatremia? What would be the answer then? What do you think, guys? Good, good. So from here, yes, the person will get basilar artery problem, locked-in syndrome, quadriplegia with preserved vertical eye movement. They can only move the eye like this. Okay, perfect. Okay, rapid correction of hyponatremia MK, not the hyponatremia itself. It's always the correction of it if you correct it rapidly. Okay, now A affecting the lower extremity will be the anterior cerebral artery, and B will be the middle cerebral artery, upper extremity and face. And the T, Horner syndrome and loss of pain and temperature on the face, that can just be any lateral brainstem problem. Okay, so that's for this one, guys. Now, one last thing I wanted to highlight, okay, is this one here. So, a 64-year-old man is brought to the emergency from sudden onset difficulty speaking. Okay, he has a history of hypertension. On physical exam, his temperature is fine, blood pressure is a little bit high, pulse is high and irregular. Again, that means it's an atrial fibrillation and it has sent an emboli to the brain. The patient appears frustrated and frequently sighs during the interviews. When asked about the symptoms, so you ask him about the symptoms. Hey Karim, what are the symptoms you are having? He understands you, but he starts to speak. He tell you speech, bad morning. He is able to follow instructions. So you tell him, he get it. Such as point to the ceiling and then touch your left ear. He does this. He can hear, he can understand you, but he is unable to repeat the phrase. So he can't speak it. He can't motor it. He can't speak. He can't move the tongue. Okay. So he say no ifs and or buts. A neurological exam also shows mild right-sided lower face drop, and they're asking which region here. Amazing. Amazing, guys. So we have Wernicke and we have Broca. Okay? Wernicke and the Broca. Wernicke is usually here in the temporal loop. And it's important to understand the words. So when I tell you like, hey Jay, you need to focus on that. You will understand my word now, Jay, by the Wernicke. You understood it now by Wernicke. Then if I ask you to open the mic and speak, your brain signals will go through the conductory pathway to the Broca. And can you see where is Broca? Broca is literally around the prefrontal cortex, motor. So Broca is here, anterior or motor. So Broca will talk. So if you have problem in Wernicke, you will not be able to understand. And you cannot like do the command I tell you. But if you have problem in like Broca, you will not be able to repeat things because you cannot motor, you cannot move the tongue. So here it's usually because this person can understand it clearly, but he can't repeat things when I tell him, right? So that means it's a problem in the Broca itself. Okay. Now, if he speaks fine, but he cannot like, so he speaks, oh, I go here to then there to the market, then like I hold like like the banana, and then I will go like sleep a little bit one while, and he speak too many things, but they don't make sense. It mean like Broca is fine, as Faizan said, but probably Wernicke is affected, right? So he can't understand words. He can't also say words that make sense. Okay, guys. Now, can you tell me which one here is the postfrontal cortex? Postfrontal cortex. Is it C, D, F, or what? Postfrontal cortex. Yes. Amazing, guys. Amazing. So that's the central gyrus here. You will always see it like that. Post will be posterior. Posterior. So this is the postfrontal cortex. And the C is prefrontal cortex. Pre is motor. Post with S is sensory. How do I know where is posterior, where is anterior? Always, this part here will always be there posteriorly. Like this is the cerebellum here, and this part will always be there posteriorly. Like you will get used to it with time. Okay, guys? So like I hope like to stay more guys, okay? But I hopefully like this one was pretty like helpful. By the way, like I tried just to go through like what I think was very important and like through like the neuroanatomy itself. And hopefully, if this one was helpful, we can do these webinars every now and then. Okay, guys. And you know the drill. I understand that some of these topics may need more explanation or any other topic, and that's why like we have like the crash course. It will go through everything in 7 days. That's very high yield on the exam. We also have like one-on-one tutoring that we can do with each other if you can request me or any of the amazing tutors. And this questions, guys, was from our the new QBank. This QBank has only like the 1,300 most high yield questions that shows up on the exam. I personally did it with other like tutors, and we worked on it for the past few months. And Dr. Asad also worked with me on it personally, and hopefully, like it would be good. So I will just like probably see you again later, guys. Probably in this webinar, or in the if you in the QBank, or in the tutoring, or in the crash course itself. Okay, and I recorded the recording, so I will also let the support team to know and probably like to send you the recordings, guys, because I think the recording may be helpful. Okay, so and thank you so much, guys. I really appreciate it. And if you need anything, probably I will put my number here just in case. Okay, so if there is anything, you can just reach out to me on WhatsApp. Thank you, guys, so much. Thank you, and hopefully I will see you like later in the next like webinar. Wish you the best.